Piggyback IOL is back-to-back two IOLs implanted in the same eye. Primary piggyback is implantation of two IOLs simultaneously to correct extreme hypermetropic eyes like microphthalmia or nanophthalmos, while the secondary piggyback is implantation of another IOL over an existing IOL to correct the post-operative refractive surprise error, and this error cannot be corrected by another option. The power of the second piggyback IOL can be calculated by a simple equation using the residual error multiplied by 1.5 to correct the hypermetropic residual error, or multiplied by 1.15 to correct the myopic residual error. Microphthalmia means an eye with a short axial length, which may be a complex microphthalmia as the small eye associated with other ocular malformations like colobomas or persistent fetal vasculature, and it may be a relative anterior microphthalmia in which the short axial length due to reduced anterior segment dimensions with relative normal posterior segment, while the relative posterior microphthalmia is the reverse, while the simple microphthalmia is a reduced both anterior and posterior segment size, which may be unilateral or bilateral, but the bilateral symmetrical simple microphthalmia called nanophthalmos. And the nanophthalmos is a dwarf eye with a bilateral symmetrical short axial length without major systemic or ocular anomalies. What is the manifestations of nanophthalmos? Short axial length less than 20.8 mm, increased scleral thickness, which may lead to vortex veins compression that may trigger to choroidal effusion, and in some cases indicate vortex veins decompression by partial thickness sclerectomy, reduced corneal diameter to be less than 11 mm, and steep K reading to be more than 46 diopters. Posterior segment manifestations like macular folds, increased retinal thickness, and a crowded optic disc. There is three different techniques for piggyback IOL. The first technique is implantation of two IOLs inside the capsular bag, but interlenticular opacification usually happens, so this technique not preferred. The second technique is implantation of one IOL in the capsular bag, and the second, the three-piece IOL implanted in the sulcus to lower the interlenticular opacification, and this technique is preferred, but may need YAG laser iridotomy to avoid angle closure glaucoma. The third technique will be discussed through such a case. Discussing the third technique through a case of nanophthalmos, aged 25 years old, K1 47 diopters, K2 48 diopters, with AC depth 3.5 mm both eyes, and this an exceptional AC depth. As usually, nanophthalmos AC depth is 2.3 mm, so this surprise confirmed by CSO. The formula was a Hofer cube. Meticulous and careful posterior capsulorhexis in a well-formed globe and well-pressurized AC with viscoelastic material. Loading of the three-piece IOL by yourself. Implant the 3-piece IOL at first in the capsular bag, then do optic capture in the posterior capsular axis to put the optic behind the posterior capsule in potential burger space, leaving a free capsular bag to the second IOL. Implant the second IOL, 1-piece hydrophobic IOL in the free capsular bag. The key of success to do this a challenging technique is a well-formed globe in all steps of the surgery to avoid any hypotony. This hypotony is risky in such cases, and this may trigger the choroidal effusion. Good view and good instrumentation. This technique has many advantages. Number 1, deep EC compared to other techniques, as the right eye is 2.6 mm EC depth and operated elsewhere, while the left eye EC depth is 3.16 mm by this technique, and the deep EC lower the incidence of angle closure glaucoma, so no need for YAG laser iridotomy. Number 2, lower the incidence of interlenticular opacification due to the presence of the posterior capsule between the two IOLs. Number 3, well-centered IOL. Number 4, no BCO in the future. This is the post-operative UBM examination for both eyes, comparing two different techniques. Note the difference of EC depth and the difference of intraocular pressure and the ability to dilate the pupil without any anterior or posterior synechiae.